Okay, in this session, we're going to be reviewing the cerebrovascular anatomy, and then the second part of this presentation will review the vascular anatomy of the lower extremities and upper extremities. So this is something you already learned in cross-sectional anatomy, and of course, everything you learn in your core classes, you absolutely have to remember because it's essential for your performance in ultrasound. So let's start with going over the basic anatomy. First of all, you should remember that the aorta, the ascending aorta, what the first three branches are. The first is the brachiocephalic, the left common carotid artery, and the left subclavian. Okay. The right brachiocephalic bifurcates into the right common carotid and the right subclavian artery. Okay, so this section right here, which they have referred to as the innominate artery, also is referred to as the brachiocephalic. Okay, so it's either brachiocephalic or innominate. The first branch off the subclavian is the right vertebral. Okay, so this is the subclavian over here on the right. And this is the right vertebral artery. So this over here is then the left subclavian. And this would be the left vertebral. This doesn't write very easily. Okay. The left common carotid artery is the second branch off the arch. So this is the first one, the innominate or the brachiocephalic. The second is the left common carotid artery. And the third branch is the left subclavian. Now, they're going to ask you this on your abdomen registry. They'll also ask you this on your vascular registry. And this is a picture showing you the right side, so you can see, I think I have the pointer on. This is the main right carotid artery. This is the internal, and this is the external. And this is what we were practicing last week. And some of the clues to help you understand whether when you're scanning, if you're on the internal or the external are listed in this PowerPoint, but I'm going to show you visually how the external is closer to the actual face and the internal lies more posterior to the external. Also, if you notice here, there are several branches coming off of the external, of which we can actually see in the neck. When we're scanning the internal, we can't see any branches because it doesn't branch until you get up into the skull. So those are two clues. And then, of course, if you perform a Doppler waveform, you'll see that the external has a waveform that's high resistant with a rapid upstroke, a sharp peak, a rapid deceleration, reversal of flow, usually just a little bit, and then resumption of flow, or what we call a dicrotic notch. Whereas the internal waveform is a lower resistant waveform, has a rapid acceleration, a broad peak, gradual downslope, and flow throughout diastole, looking more like that. So the internal waveform and the external waveform are very different. So the external is a higher resistant, or it may actually look like this, where it's more moderate. It just shows the notch and then it comes up, but it doesn't actually reverse. So those are two looks to it. But the biggest difference is these have sharp peaks and a notch, whereas the internal does not. And a couple of landmarks. Common carotid artery branches, of course, into the internal and external. And the location is medial to the jugular. So if you have the jugular and then you scan medially, you'll see the internal and external, or the main carotid. and go in too far and you see the thyroid, you have to scan back out laterally. And again, here's a list of characteristics of the internal. So the internal, these are the characteristics of the internal. Should probably change the color. Okay, the internal is posterior and lateral to the external. It is slightly larger than the external in diameter. There are no visible branches in the neck. It has a low resistant waveform. Again, look more like this. Broad peak coming down like that. And it supplies blood to the brain and the eyes. The external, on the other hand, is anterior and medial to the ICA. It has a smaller diameter than the internal carotid artery. It has branches in the neck that we can see. The waveform is high resistant, or actually it's higher. It's actually more moderate, as you're going to learn what the differences are. So it has that sharp peak, rapid deceleration, a dicrotic notch, and then it comes back up like that. So again, the peaks and the notch are characteristic of a higher resistant waveform. And a response is something we call the temporal tap, which on the next slide I'll show you what that means. And it supplies blood to the face, neck, and scalp. Okay, on this picture here, they have it labeled external and internal. As you can see, the internal here is a bit wider than the external, okay? This section right here we refer to as the bulb, okay? And again, the internal is a bit wider. And the waveform, although the gain is set way too high, and we are going to learn that as well, that this is not appropriate, because what's happening here when the gain is set too high, it's making it look like this is all shaded in here, when in fact it should be nice and clean and a clear window. So we would have to turn down the Doppler gain. This is really hard to write. Okay, because what we want to have is a clean window. Because if this isn't clean, that may indicate to the radiologist who's reading this study that this person has turbulent flow. Clearly we can see that their gain is too high here in the grayscale display, and the gain is too high in the Doppler display. So both the grayscale, the TGCs, and the gain have to go down. Okay, so the gain should go down here, and the Doppler gain needs to go down. We don't want this window filling. Now on the external, again, notice the sharper peak, the dicrotic notch, and the resumption of forward flow. See these little deflections here in the diastolic? That's what we refer to as the temporal tap. Since the temporal artery is a branch off of the external carotid, when we tap around the area just in front of the temple, you're going to see these little deflections in the waveform. Now, why do we do this when we can see that this is external because it has the sharp peak and the rapid deceleration and so forth? Why would we do this to differentiate it? Well, sometimes with disease, the external will mimic the internal because the arterioles vasodilate in an effort to get more blood to compensate for a possible occluded internal carotid artery. So if both these waveforms were to look like the lower resistant, like the internal, the only way we might be able to differentiate between the internal and the external is to do the temporal tap, which is shown right here with these little deflections in the diastolic component. The vertebral arteries arise from the proximal branch of the subclavian artery. They pass through and are protected by the cervical vertebrae. Both vertebral arteries anastomose in the back of the skull to form the basilar artery. And I'll show you how this joins and becomes part of the circle of Willis. It supplies blood to the posterior aspect of the brain, and retrograde flow indicates a possibility of a subclavian steal, and I'll kind of explain that too. If you're looking at the vocabulary worksheets that I gave you earlier, a subclavian steal is one of the words that you need to look up and make sure that you define all of the vocabulary. Anytime you come across a word when you're reading and you don't know what it means, you need to look it up. Well, this is a good time to give you a little lesson on color flow. Let's say we had a color map, and the top of the map was color-coded red, and the bottom of the map was color-coded blue. If you remember from physics and also from last month's class, we talked about how to read the color map, and we said that the color on the top is always the positive color flow assignment, and the color on the bottom is always the negative. Now, red doesn't always have to be on the top, and blue doesn't always have to be on the bottom, but positive is always at the top, and negative is always at the bottom. So whatever that color may be, the one that's positive is at the top of the screen. So if you look at our display here, the first thing we need to know is we're looking at the vertebral arteries and veins. So if we're trying to determine which one's the artery and which one's the vein, assuming that they both have antegrade flow, how would we use the color map to distinguish flow direction? Well, first of all, we need to know that the artery is supposed to be flowing in this direction. And the vein is supposed to be flowing in this direction. Oops, that was not very good. And this is superior as long as you have your probe correctly positioned and not upside down. And this should be inferior. Okay, so if we know this is the first thing we need to know. The second thing we need to be aware of is what direction is our color box being steered towards. And in this case, if you look at these lines right here, and there's a slight tilt, okay, this is the direction that the color box is being steered. So the way we receive a positive shift, or the only way we can receive a positive shift, is if the return frequency, the FE, is greater than the FO. Okay? That's what the machine reads. It says if FE is greater than FO, then it's told, because it's programmed this way, then positive. So whatever color then is positive will be filling in the positive shift. So if you remember from physics, the only way we can receive a positive shift is if the return frequency is greater than the operating frequency. And that only happens when the sound source and the receiver are coming at each other. That's a positive shift. If the sound source and receiver are going the same direction or opposite directions, then it's a negative shift. So if this is filling in red and red is positive, that means the blood is flowing in this direction to the sound source. And if this is filling in blue, then that means this one is flowing in this direction to the sound source. Therefore, these two arrows are chasing each other. These two arrows here are chasing each other as they are here in this negative situation, and therefore are color-coded blue. These two arrows are hitting each other. The flow is coming towards the direction of the beam, and therefore we have a positive shift, or the return frequency will be greater than the original frequency. So hopefully this is just a review and it's all coming back to you and you guys remember this. If not, you absolutely have to know how to read your color map and your Doppler display spectrum. Otherwise, you won't be able to perform accurate vascular scans. The circle of Willis. The basilar artery is the vessel in the back of the brain, okay? And only 50% of the population has a complete circle of Willis. So we have the posterior cerebral vessels connected to the carotids, the internal carotids rather, by the posterior communicating arteries. And then we have the anterior cerebral vessels connected to the internal carotids by the anterior communicating, okay? And again, only 50% of the population has a complete circle of Willis. Now, a subclavian steal is just as it implies. It's actually stealing something, okay? It's a steal. What's being stole is the blood that's supposed to be going towards the back of the brain is now instead going down the side, the left side, and the arm is stealing the blood, okay? This happens when you have plaque buildup and not enough blood is able to go in the direction it's supposed to be going. Let's see if I can draw this. If the blood is supposed to be going through here, but it's too narrow and very little is getting through, blood is going to move from an area of high pressure to an area of low pressure, right? So if there's not a lot of blood here, the pressure is very low. Let's just say it's 20 millimeters of mercury, because that's what blood pressure is measured in. That's Hg. And let's say the pressure here at the basilar artery is, let's say, 40 millimeters of mercury. Well, blood is moving up here, right? It's moving up here. And blood is also moving in this direction up here, right? This is the direction of flow in these vessels. Now, since there's no flow getting through here, or very little flow getting through here, the pressure is very low. So if this is 80 millimeters and this is 100, again, blood moves from areas of high to low. It's 100, it's going to 80. And if this is 40, some of the blood's going here, but over here it's 20. So we also have blood going down here because there's no pressure down here and blood has no choice but to move from an area of high to low pressure. So what we end up with is what we call retrograde flow. We've talked about it a lot. Retrograde flow in the vertebral artery indicates a possible steal on that same side. Okay, so this is retrograde flow of the left vertebral artery indicating a steal on the left side. Um, we did a couple of anatomy pictures last month with the black and white images along with the color box, but the Doppler beam is no different than the color box, except it's more angle dependent. You don't just send in angles that complement the tilt of the vessel like they did here with the color box, okay, that complements the tilt, right, of the majority of the vessel. But we also want to send in our Doppler beam with that same angle. And this time we have to line up our angle correct with the vessel wall so it's parallel, and that should be at 60 degrees. Okay, so that's the next thing you're going to be practicing, is lining up. Now, don't confuse that with this little thing that we refer to as the gate. That's just the area that the spectral analysis is being derived from. That's like the little microphone. So when you look at your spectral waveform, the only information being plotted on that waveform is coming from within this little gate right here, okay, from within the gate. This is what we need to make 60, and we need to line it up with the vessel wall. This does not line up with the vessel wall. We can just open it or close it, increasing or decreasing the range of velocities that we plot on our Doppler spectrum. And this slide pretty much is just kind of showing you how you have options. You can send in the beam in different angles. If you send it in at a very sharp angle, this looks like it's less than, I don't know if you guys can see these angles, but if you can eyeball the angles, and we don't have to eyeball the angles, that's why we have the angle correct, so that we don't have to eyeball them. But if we were to eyeball the angles, this is the angles we're talking about right here. This is what angle is basically created. It's the beam to the flow. So that's a small angle, like 30. So you're going to get a very strong Doppler shift. Here we have an angle more like 60. So that's good, right? And the flow is coming at the beam. So that would be positive. This same scenario here, we have a 60 degree as well, but it's going away from the beam, so it would be negative, which is why this one and this one have the same velocity. They're just in different directions because they both are 60 degree angles. And if you remember, the cosine of 60 degrees, cosine of the angle is equal to 0.5, which is half of the true velocity. So both of these are just as accurate. The velocities are exactly the same. So if this is, say, 40 centimeters per second, this will also be 40 centimeters per second, except it will be on the negative side, whereas this is on the positive side. And this one, this angle's too poor of an angle. It's way too close to, this is actually what 90 would be. So this is actually an angle of about probably 70 degrees. So that doesn't yield a very strong cosine. Therefore, we're not going to get a very strong percentage of the signal that we're picking up. Whereas this one is a 30 degree or 20 degree. Let's say it's 20 because that's a pretty sharp angle. So that's actually going to yield a stronger cosine, be much greater than half, maybe even 87%. But it's still not accurate if our charts are set up for data to be read at 60 degrees. All that data will be erroneous if you scan at an angle much smaller or much larger if the chart is set for 60. And that's it for this section. Let me go ahead and Well, I don't think it's going to let me do 2 slides at once, so we'll stop this presentation and then I'll review the anatomy of the arteries and veins of the legs and arms.